So this was on this paper which looked at, let's say it's a follow-up from Amit's talk. So what we're trying to show is what is the evidence now on endometrial receptivity and selectivity. And the reason is because across, from Dopplers, from endometrial thickness, name it, and NK cells and ERA everywhere. And what have we done? We swear that we have found an answer. And so this was one of the best reviews done by one of the finest groups from across the world, which looked at what could be a problem with endometrial receptivity. So let's look at the endometrium, and there's something known as endometrial receptivity and endometrial selectivity. And this is quite a beautiful way of explaining what goes on. And it's, in fact, important that if you think along these lines where the researchers have thought, then we are more likely to understand and explain to patients. So, and both of these are complementary. So what is selectivity? And it's an intrinsic programmed function of the endometrium to recognize and reject embryos with a reduced developmental potential. And in fact, that has been taking a certain amount of importance. Receptivity enables the endometrium to provide an optimal environment for embryo development and placental formation. So let's have a look at it again. And if you see, almost all our tests are heading towards receptivity rather than selectivity. So implantation failure is a consequence of impaired embryo developmental potential.
Anil, can you let Andreas in? I can't.
Yeah.
There are a lot of people waiting to be let in.
Yeah, I've let everyone in. So, an implantation failure is a consequence of impaired embryo development potential or impaired endometrial selectivity and receptivity. So, if we go back and in summary, what they had said is, let's see what to look at. And they looked at endometrial thickness, endometrial volume, endometrial pattern, endometrial blood flow, endometrial contractions, histoscopic inspection, uterine natural killer cells, and endometrial receptivity, that is ERA. And I think we have already spoken about ERA. So let's go back to endometrial thickness, something which we think we know the answer, and I'll show you how little we know. So let's say if we took a 6 millimeter cutoff, and that was based on 4 studies of close to 28,000 cycles. And I think that is the only bit of evidence where we think we've got some answers. The highest sensitivity was at 99%, and the lowest specificity was at 0.98. And if you put the endometrial thickness higher, which is you put it at 14 millimeter, then you're looking at a low sensitivity and a high specificity. So, and that's probably the only matter in which we have got, I think one of the problems with Andreas is trying to keep coming in, and it's not letting him come in from Cyprus. So if you looked at endometrial volume, and people have tried to see, is there any role of having being very specific? And they looked at a volume of endometrium more than 2 ml and realized that it seemed to have a reasonably good sensitivity and a lower side of specificity. But again, there was insufficient data to consider endometrial volume and say that that was one of the ways of predicting pregnancy rates. So if you look at endometrial pattern, and this is again something which we have used constantly, is the endometrium trilaminar or is it not trilaminar? So 20 studies were done which looked at IVF for around 15,000 cycles. And they found that the pregnancy rates, whether you had a trilaminar lining or no trilaminar lining on a day of HCG, was very similar. Then there were 3 studies which looked at 719 cycles, and the clinical pregnancy rates, whether it was trilaminar or non-trilaminar, was very much the same. And then they looked at the triple line, and the sensitivity was around 87% and a specificity of 15%. So if you look at Doppler signals, and again, this is something which I think I hear everyone swear by, and I'll show you how poorly documented and how well sold it is. So it was 22 studies, and when you look at the endometrial vascularity index, that's VI, 4 studies were done, and the EVI was slightly higher on the day of HCG in women who got pregnant and those who did not. So what does that tell us? And that tells us, well, you look at that factor, and it tells us that, fine, we know the answer, so endometrial vascular should be high. But then you look at endometrial flow index, and they had 3 studies, and in fact, it made no difference whether the endometrial flow index was good or bad. So then they looked at another index called the endometrial vascular flow index, and there were 3 studies with 805 cases, and the results were exactly the same, irrespective of whether it was on the day of HCG. And the 2 studies contraindicated those, and they said that in 527 cases, women who fell pregnant had a higher endometrial vascular flow index. So then you go to subendometrial index, and there's no difference between the groups on the day of fresh embryo transfer. So again, somebody says, let's look at subendometrial flow index, and differences were seen in one study and differences were not seen in another study. We go to the commonest thing that we aim to look at. We look at uterine artery pulsatility index, and 10 studies, 1,714 cycles, and the PI was similar in pregnant and non-pregnant cases. And that was measured at endometrial thickness. And there was no difference in the outcome measured on the day of egg collection. So if you look at the uterine artery RI measured on the day of embryo transfer, and the resistance index was similar in pregnant and non-pregnant cases. Frozen cycles, again, there were no difference in outcome when you looked at the Doppler signals. And they've started using a new technology called a spherical endometrial spatial temporal image, and to make it sound a bit better. And they compared it with the manual assessment, and they found no difference in Doppler signals. So the simple question which we have to answer is, when you use it aggressively and you swear by it, let's go back and say, is there any evidence that comes up that supports Doppler signals? So, and there's a reason why we don't have any clear answers. So 3 studies were done, and they suggested that if you see endometrial flow, then pregnancy rates are higher. Further, 3 studies, we looked at almost 1,000 cycles, showed that the endometrial blood flow on the day of a fresh embryo transfer was not associated with higher clinical pregnancy rates. So you look at another factor. So, and this is what we have been taught for many years, and it is, if the uterine artery pulsatility index is less than 3, on the day of fresh transfer, it's associated with slightly higher clinical pregnancy rates. So in summary, there's insufficient data available to perform accurate meta-analysis. So in fact, if somebody says we know that Doppler works, in fact, research says that we don't know whether Doppler works, and we don't know whether we are measuring the right thing. If you look at almost all the parameters, we just don't know that. So then we come to the endometrial wave pattern, and this is something which we have often spoken about, and there were 6 studies, and the data is quite incomplete. So what we noticed is, and this started in 1997, when for unexplained infertility, endometrial activity. I think I'm going to mute all. So in unexplained infertility, endometrial activity was looked at for every 3 to 15 minutes. And those who conceived, that is natural, and just in 37 cases, 27% conceived, there are lower endometrial patterns. So this was something new that came up. And again, you go to many meetings and they'll say, let's start calculating wave patterns. So if you start calculating wave patterns, what I'm doing, I'm just admitting people at the same time. So in 2014, a review of 241 cycles was done, and they looked at 3-minute endometrial activity. And those who had a reduced activity had a higher pregnancy rates, but they also had a higher cervical-fundal movement. So if you see what happens in around the time of ovulation is, pulsatility movements go from the cervix to the fundus. And the reason why it happens is nature, is it's quite normal in nature. It happens because it's the way to push the sperm up. So really we don't know very well what is happening in these cases. So in 2017, another study was done, and they did ultrasound 5 minutes before, 5 minutes after, and 60 minutes after embryo transfer. So there's no difference in clinical pregnancy rates 5 minutes before transfer, but contraction was reduced in successful cycles 5 minutes after transfer. Then somebody looked at it and said, oh, let's look at what level can we see better pregnancy rates? And they noticed that the clinical pregnancy rates were the highest when fewer than 2 waves were seen, and decreased when more than 3 waves were seen per minute. So if you again have a look at it, we just don't know an answer about that at all. And how many contractions should be there? But equally worse is, what is the treatment for it? And at present, there is no treatment that seems to affect and lower the contractility. So then the question came up is, can we do a biopsy? And can we look at, and there are clinics that do biopsy and look at uterine NK cell assessment, and they look at endometrial dating. And again, this was suggested in 1950, where histological endometrial dating in unexplained infertility was done. And what they noticed is there's something known as a retarded endometrium or phase endometrium, and retarded endometrium tends to have a lower chance of pregnancy. So Professor Siobhan Quimby again looked at it and said that there were higher CD4, CD8, CD14, and CD16 and 56, which were observed in unexplained recurrent miscarriages. So in 2014, they combined histological dating with uterine NK cells to predict the fate of future pregnancies in 83 women with recurrent miscarriage or recurrent implantation failure. And there was no correlation with the uterine NK cell count and subsequent pregnancy outcome. And what they noticed is that you had a retarded, it means a lagging behind endometrium, had a slightly higher miscarriage rate compared to endometrium in phase. That's not a new data. So if you look at the earlier studies of the 1930s and 1940s, in fact, they realized that if your endometrium was out of phase, miscarriage rates seem to go up. But again, data is very limited, and you can't comment on these again. Amit has spoken about ERA, so I'll just briefly talk about it. And ERA looks at receptive, pre-receptive, and proliferative phase expression in 238 genes, of 238 genes. And that limited study tells us that the non-receptive endometrium varies from between 25 and 37% of cases in recurrent implantation failure. So I take this from Amit's slide, and Casper and Oveto challenged ERA and basically said it doesn't really correlate well with the classic noise criteria. They showed the evidence that only 50% of patients with receptive results got pregnant in the subsequent frozen embryo replacement. Again, from the pre and post-receptive group, only 33% conceived in subsequent FER cycles, which was similar to 35.2% in backgrowing ongoing pregnancy rates in women who did not have ERA testing. And again, the meta-analysis was not possible because of the low number of cases. So what are the other markers? And the other markers which are present is people looked at endometrial fluid aspirate, and they looked at cytokines, TNF. Again, data is very, very limited in those cases. So people looked at looking at endometrial receptivity by hysteroscopy. And in fact, all of us did that. We'll have a look at the endometrium and say, there looks to be a good endometrium. And that's how you see well-developed vessels during hysteroscopic assessment. And they said, well, if the endometrium looks good, pregnancy rates would be higher. But again, the data is quite insufficient. So where did this discussion come now? And what do they mean by selectivity? And this is quite a beautiful chart which they have done. And what they looked at receptivity, and have a look at the euploid embryo here. And if you look at euploid by age, as you get older, the chances of euploidy start changing. And by the time you reach 40, so have a look at what happens between 35 and 40, and what happens at 40 plus. And 40 plus, aneuploidy rates start skyrocketing. And in receptivity, if you have a euploid embryo, you are dependent on a receptive endometrium to give you a successful pregnancy or having an implantation failure. So that's where receptivity comes in. And where the selectivity comes up, and a selectivity decision is not from the embryo, but to a large extent by the talk that goes on between the embryo and the endometrium. And which means that the embryo decides that the endometrium decides that it may be time to deny implantation or cause an early miscarriage. So in this way, if you're going to split up the data, it seems to make more sense. Why? Because again, embryos that account for implantation failure, which are genetic in origin, seem to be aneuploidy seems to be about 33%, and 66% at present seems to be between the talk that goes on between the embryo and the endometrium, and whether there's an altered endometrial dialogue response.
And your voice is breaking up quite a lot.
Is it? So let me. Is it okay now? Hello?
Yes, yes.
Okay.
It freezes and it breaks up, I'm afraid.
Okay.
It's not your fault. It's just, I think Zoom is not working properly.
I think we've overloaded, Zoom's got overloaded probably. So if you look at it from a study's point of view, let me see if I can go back. No, just a minute, let me go back to this and. So if we go back to the review and we looked at what is the quality of review, and the quality of review seems to be very moderate. And in fact, they can't predict clinical pregnancy rates. So if you think that endometrial thickness is the most common investigated marker, you cannot predict clinical pregnancy rates on endometrial thickness, which means you can't look at endometrial thickness of 7 millimeter and say, you've got a 50% chance of falling pregnant. So it has a poor ability to predict clinical pregnancy rates. And it does not discriminate between cases that achieved a clinical pregnancy following IVF and those that did not. So again, we look at endometrial volume, endometrial pattern, Doppler signals. Again, the evidence is very low quality, a lot of bias, inconsistency, and imprecision. In 2018, they had a look at Doppler signals and it said, well, there seems to be significant associations. But again, these studies are smaller. So what happens is, new studies come up and you decide, yes, we found something new and that association seems to go through a meeting and people start using it. But again, research doesn't support it. ERA again seems to be promising, but it's insufficient data. There's a new one which one of the Spanish clinics is doing. It's called ER-MAP, ER-grade, which is a new way of looking at endometrial receptivity with 184 genes. Again, if you had a look at endometrial thickness between clinical and non-clinical is similar. So on the basis, if you looked at what is the strongest association, and that's an endometrium of 6 millimeter cutoff, which seems to have the strongest association. Why did we present this study? Because I think it is a first systematic review which summarizes the clinical value of existing endometrial receptivity markers. There were 160 studies with more than 40 markers, and none of the endometrial receptivity markers included in the present review has sufficient discriminatory value to act as a diagnostic test for endometrial receptivity based on their ability to predict clinical pregnancy. And the other new things are weighted. So again, why is it important? It's what we tell patients. If you're going to go and tell your patients that, in fact, let's do ERA, you have to be very frank with them and say, well, the evidence is limited. If you look at endometrial waveforms, Dopplers, I think everywhere the evidence is limited. It may help us to attain our final aim of trying to fine-tune treatments, but I don't think we know much about it. So in summary, if you look at endometrial thickness, again, 6 to 7 millimeters seems to be there. Endometrial volume, again, a positive result based on only one study. Endometrial pattern, we don't know whether that trilaminar structure has any importance. Endometrial contractions, again, very limited studies which give us any idea. Hysteroscopy, again, seems to be good, but it's very much visual. Uterine killer cells, again, no proper studies. And again, endometrial receptivity assay source of data is inadequate. So, that's in short on the endometrial receptivity, the selectivity and the receptivity. So I don't know, Amit, do you want to go through your talk?
No, Anil, I would rather not because it's very patchy. The voice and stuff is breaking up quite a lot and it doesn't maintain the flow. I would rather do it mine next week. We could rather have some discussion on this if people have been able to hear.
Okay, if you could drop in some messages. So,
or just raise hands and take questions.
But sadly, Anil, there is not particular any positive take home from this paper. In the sense, as a clinician, what will come to our mind is what criteria I should fulfill to say that I am safe now to do a frozen embryo transfer or embryo transfer. So and looking at endometrium. So what it would be? Would it be just a thickness of near 8 millimeter in a program cycle and 7 millimeter in non-program cycle, and that's it? Or do we dwell into things, or we keep keeping the data and come out with an new evidence sometime in the future?
So, see, what this paper wanted to emphasize on is if at all there is one element that has the highest rated prediction, it seems to be the endometrial thickness of less than 6 millimeter. Above that, everything comes with a big question mark, and I think we should be telling our patients that. The reason is that I think this paper, its importance is huge, not because it tells us what to do, but it tells us have a rethink about what you're doing. And as clinicians, I think it's very important for us to be able to tell our patients that, hang on, there seems to be this technology, it seems to be good, but at present, we don't know how helpful it would be. But I would recommend it on that basis. That may give us some more answers.
And could it be also this, like, we have so many evaluation points, like the thickness, echogenicity, you mentioned all of them. When the report of that particular test is very bad, probably it indicates, well, we are not going to be successful. But if it is good, it doesn't predict whether we are going to be successful or not successful. Do you think something like that would be there? So, like so many other tests in our practice, like our AMH and everything also, when it is very bad, it is highly predictive of something. But if the report is near normal, it hardly predicts anything.
So let's look at endometrial flow, and then you say, what do we use? RI and PI research doesn't tell us much. When you look at one form of endometrial flow and that is positive, and then you look at another form of endometrial flow and that's negative. And I think what I generally believe is often we even with the best quality of embryos, and even with euploid embryos, and this is something which I tell patients, and we do a lot of pre-genetics PGTA, and sometimes genetically normal embryos don't seem to implant. And so what do you tell patients? And as soon as you tell patients that there is a technology that can give us some more answers, and let's look at the evidence is lacking. So I think it helps us to come to a conclusion often when we tell our patients that, well, I think we've tried everything. The science is still unknown, and we don't know the answers. And sometimes that's really what happens. What do you say, Amit?
Yeah, it's very difficult for doctors to say no to patients, isn't it? That I don't know. And that is the hardest bit. And I think we have to be honest and we have to be truthful that this is all we know. The rest is all a bit of a guesswork. It might work for some people, it may not work for other people. And that's why I wanted to join in and present. But I think the Zoom today is so temperamental that I don't want to start the other talk now. But that is focusing on the endometrial compaction, which seems to be a very, very important factor. And there is one particular group that seems to be working quite a lot on that. So basically what it means is that endometrial thickness, yes, 6 millimeter may be a good cutoff, but what is equally important is that once you make a decision to start your progesterone, whatever form of progesterone you're going to give, you need to see a thinning of endometrium around the time of transfer. So if you are still seeing a trilaminar endometrium at your embryo transfer, something is not quite right. That is the critical and a crucial bit. But we'll look at that evidence next week and sort of continue with the whole process of endometrium. What do you think, Sachin? Have you read about it a bit and have you looked at it?
Yeah, I've read that paper on compaction. I think it was Casper et al., if I'm not mistaken. This was about once you start the progesterone, have a look at the trajectory of the endometrial development when you complete your estrogen and put you onto progesterone, and whether there is a difference, whether the endometrium compacts, it decreases by 1 millimeter. Well, it looks like a very interesting concept, but Amit, I feel to execute that concept, there are going to be quite a bit of issues about this 1 millimeter being such a small marker there. A lot of inter-observation differences would be there. And I doubt repeated replication of the study would tell us the same story. It worries me.
They moved away from the numbers. There is no 0.5 millimeter or 1 millimeter or anything at all. It's basically just about thinning and not seeing a trilaminar endometrium at the time of embryo transfer. I mean, the downside of it is that it's still early days. We don't know, just like everything else. But then what else is available? Yeah. There is nothing else. And I think that we should, rather than looking at ERA and this and that and make patients spend thousands of extra pounds or rupees or whatever currency we use, I think we should rely on as much clinical that we can. Rest doesn't seem to matter. So Dopplers, as Anil showed, and ERAs and all endometrial receptivities, and it all seems to be up in the air.
So in fact, what the HFEA, which is our regulating bodies, is sometimes right in it, and it gives a traffic light signal for patients to see. And much of this, it puts in red. Red basically means the evidence is very lacking. Amber is somewhere in between, and green says there is good evidence. And in fact, that is for patients to see. So it's available for patients. So many patients would go up and see it and say that ERA, or let's say Dopplers, or many of those other things, isn't much evidence there. But patients would still come back and say, I want something done. Because there's a difference between what research tells you and what marketing tells you. So you Google and somebody will come up with a story and say that I tried the ERA test and it showed me the implantation window. And we have had that recently. And I think I had a patient and Amit had a patient where the ERA said, replace the embryo 6 hours earlier. And we did that. and she got pregnant. And so what did the lady say is, it's because of the ERA test, which may not be so. So, there's something which we have to draw a line between science and marketing, because the online web will aggressively market anything that we want. So, so if you see, there's been a video which I put on how long should you give estrogen. And what we think happens is the minimum amount of days you need, and that's not a set rule. So if you say, tell me the exact number of days which estrogen should be given on a minimum range, there's no such thing. And it seems that your pregnancy rates tend to start stabilizing after 9 days of estrogen. But on the other hand, you'll still see pregnancy rates with 7 or 8 days of estrogen. Now, the problem is that the longer you continue estrogen, and sometimes you don't end up seeing a thickened endometrium, you end up seeing the endometrial thinning which goes on, because I think that causes over suppression, and that's what I believe.
Agree.
So is there any role of uterine artery pulsatility index? And in fact,
No.
probably no. In fact, that's what, if you looked at the...
But you just showed that there isn't any.
Should a study be launched on Doppler and FET endo preparations? I'll tell you the problem with Dopplers is that, who are the best people to do Dopplers? Fetal medicine people, and there's no doubt about it. And in fact, who taught me Doppler? Somebody in fetal medicine. And I think while there is a role in looking at the fetus and its Dopplers, I don't know whether the similar role is looking at the endometrium and looking at the uterus. I don't have an answer. I don't do Dopplers because I can't really find a convincing evidence that it will change my practice. It'll probably confuse me and confuse the patient. Sachin, are you planning to do Dopplers, a study?
No, I just find whenever the endometrium is not developing, the Doppler is poor. And if the Doppler, the blood flow is good, then endometrium really develops well with 7 to 8 millimeters. I really don't see any difference. In my practice, I've stopped doing Dopplers just for the FET sake. But in India, it's a huge fashion to do Dopplers, let me tell you. It's a huge fashion. A lot of people do Dopplers for endo. But then I feel, how much are you going to censor your FETs? You're going to do Doppler, you're going to look at the thickness, then you're going to look at the E2 level, progesterone level, again progesterone level on the day of FET, and then compaction. So many factors coming in together. You're really doing so many things to match for that perfect embryo transfer to take place. I think we are over censoring the procedure.
So Chaitanya says, is there any role of doing progesterone? You know, Chaitanya, what I thought it was dinoprogesterone. I said, gosh, what is that? It's doing progesterone day of adding progesterone in FET cycles as we do in fresh cycles. No, I'm a bit confused, right? I didn't. So, okay. Is there a role of measuring progesterone in a frozen cycle? And the answer is probably yes. And I think at least there are 3 good studies which suggest that progesterone levels in a frozen cycle is linked to higher pregnancy rates. In a fresh cycle, I don't think we really know the answer. And is there a role of doing progesterone day of adding progesterone FET cycles? Okay. What does that mean? Amit, and Sachin, would we do progesterone a day we are starting progesterone levels? Why? Unless you have a follicle growing, and that's the only reason why I would do it.
Yeah, so true actually. In a down-regulated cycle, they definitely no. But again, in my practice, I do it. I do a serum estrogen and progesterone level on the day when I want to shift out to progesterone. And a target is progesterone to keep it less than 1 and E2 beyond 200 picogram. But is it necessary, or will it be any different if there is no follicle there? I think if both ovaries are quiet, I don't expect the progesterone to go up anyway.
So if you have a look at progesterone itself, and in PCOS, follicles which are less than 4 millimeters start secreting progesterone. So again, we don't know whether in PCOS patients it's better to downregulate when you do an FER cycle, and again, the evidence is not there. So, I tend to err on the side of caution. I'll downregulate PCOS women who are going for a frozen embryo replacement cycle, but I can't back it with evidence. And all of us do things that we can't back up with evidence.
I think doing more blood tests just muddles up people's mind much more. You don't know what else you're going to do. And how will you, and it then becomes like a little game that you have seen this level, so you react to it. Whether it's going to make a difference, I don't think so. It will just make your treatments more hodgepodge and more confusing for everyone and patients. But I put it this way, Anil, that if the implantation rates in a frozen cycle with a good quality blastocyst, let's even forget about doing PGTA, is approximately 40%. Is that right, Anil? Would you say so? Minimum?
Yeah.
And in younger age group patients, it would be even higher. So I don't also quite understand that how much or what is your expectation as a clinician. Of course, as a patient, your expectation is 100% every time. But as a clinician, we need to tell patients that that's not going to happen, and people will take more than one attempt to get pregnant. So I think it's also about building expectations of yourself and your patients that don't have unrealistic expectation that every embryo transfer cycle is going to work. It's a bit too much. You're not doing anyone a favor. So by doing all these things and making interventions where they may not be needed, by doing tests and various tests, which cost a lot of money, if your pregnancy rates are going to increase by another 2% or 3%, is it really worth it? And that's the question that we need to ask ourselves, that we need to be honest with patients and say, well, look, this is the best we can do. Of course, if your pregnancy rates are running at 20%, then you've got a problem and you need to sort that out. But if you're running a good 40-odd% pregnancy rates, implantation rates of 40, 45%, then you should be happy in some way. I'm not saying that we should all be dancing with joy, thinking, oh, great, good job. We can always do better. But there is a limit to this science.
So, Primarin, gosh, I've not used it since I left India. Any idea, Sachin, on Primarin?
No, I don't use Primarin for endometrial preparation. I use only Proganova for my program cycles.
So in a stimulated cycle for FET, can you please explain timing of starting progesterone? The general rule is 120 hours, and so it's 5 days of progesterone for a blastocyst transfer. And in fact, we, in fact, a large number of people who are on this have come through the IBC courses, and I think we have discussed it at the IBC courses. So that's what is the general rule. Apart from a topical case of recurrent pregnancy loss conceived in third cycle, how long should I continue heparin? Can I stop at 12 weeks or should I continue? Again, the evidence on, in the case of absence of thrombophilia, in fact, they've done a lot of studies which showed it makes no difference whether you give heparin or not, and many of us do give heparin. And usually what I tend to do is if somebody's been on heparin, I hand it over to a fetal medicine person and say, well, have a look at the Dopplers and then decide whether to stop it. Well, a lot of people will stop it by about 10 to 12 weeks.
Yeah, I think if it is started empirically anyway, so it's worth stopping at 12 weeks. But you look at the whole thing holistically. Your patient is obese, she has a history of PCO, she has a metabolic syndrome already set in, she has had the previous abortions and which are hinting towards a syndromic diagnosis. So like the FH appeared, and and around 10 weeks onwards, there was a sudden demise of the baby, or there's placental evidence of a placental insufficiency been there. So you're correlating all these things. And if when you do a NT scan, if the Doppler says the uterine artery it is having a high resistance flow, and probably may continue till about 20 weeks. But otherwise, if it is empirical, best is to stop at 12 weeks, no doubt about it.
Yeah, I think, Amit, you are replying to the message, isn't it?
Yeah.
So
I mean, sorry, Anil, go ahead.
no, go ahead, go ahead.
No, I was just talking about, people still keep talking about this routine post-ovulatory scan. I still don't understand. I mean, how many times have we discussed this before? Do you agree, Anil?
Yes, absolutely.
Why are you doing it?
Um, one. I'll tell you what I do in to find out if ovulation has occurred or not. And I think the simple thing I do is I do a day 21 progesterone. And if the day 21 progesterone is low, then either there's been a suboptimal trigger, which means that HCG has not been a very good trigger. And we know that in IVF that HCG is not the best trigger. So in effect, we're not saying anything very different, are we? So if in case serum progesterone is low, and it happens, your ovulation happens and you give HCG, and serum progesterone comes back as 27, exactly, because you can time it quite well. And then what I tend to do is I'll say, well, there's some problem. And I had yesterday somebody on my patient information evening who said that. And I said, why don't we give you a dual trigger? Why don't we use agonist and HCG? And there's a small data that we have which shows that progesterone levels rise in a dual trigger. And I would not scan somebody immediately after, because I think what happens, it just increases my workload without, in fact, increasing the success rate. Because ovulation induction gives you about a 10% success rate. And I don't think we, by intervening, and eventually I think it just takes a lot of our time, it takes a lot of patients' time, increases cost, and more often I think it confuses us tremendously of what we do next. In a frozen embryo, what's the maximum dose of Proganova and maximum duration? I'll put it this way, I don't go beyond 8 milligram, and the reason is I think it doesn't in fact do anything once you cross 8 milligrams. So it's very rare that I'll go to 10 milligram. And how long do I continue? If I don't get an endometrium by about 14 days, I think it's not the drug. And I tend to blame the drug more than the patient, because as humans, we respond differently to different drugs. And I'll change the drugs over and go to patches. Absolutely. I think me and Amit speak on the same tone here. Any questions? Anything else? So I think poor Andreas could not join. I think he kept joining from Cyprus. He tried his best. But I think he could not. Should sildenafil be added to whom? I think I generally believe you add Viagra to the husband, it has better results than to the wife. But again, it doesn't seem to. It seems to help some people and it doesn't seem to help others. So in fact, it causes breakdown of endometrium in some patients, and it seems to improve endometrium in others. So I don't know. So in fact, I've never used it. And I don't think, Sachin, do you use it?
No, I don't use it.
So I'll tell you what happens. If the endometrium is thin, I'll say, why is it thin? And first blame the drug and then the patient. So I'll say, well, we're using a different drug, and Proganova is quite a bad drug. It goes through a first pass effect. So what I'll tend to do is I will lower the dose of Proganova to 2 milligram. And sometimes that gives you a far better endometrium than giving 6 or 8 milligram. And the second thing which I end up doing is I use a lot of patches, and the Spanish use a lot of patches, and it seems to go past the first pass effect. So I think it's been a good group. I think we've got people from London, and we've got people from India, and we've got people from South Africa, and then we've got people from Greece and Cyprus and Bangladesh and Pakistan. Fantastic! I think it's a nice group, and I think as you said, is many of those in a group are who've been to our lectures in the IBC, and I think that's where we discussed all these majority of these protocols. And I think it creates a good group through which we can discuss cases. And I think at present, doing any course in a conference is almost gone. So maybe we may move to online courses, but we don't know. Endopulsatility by my 2D machine. Yes, I think it's very common. I think what tends to happen is the uterus contracts throughout, it's right from the menstrual cycle. So if you look at nature in menstrual cycle, when a menstrual cycle starts, contraction go from the fundus to the cervix, and that's quite natural because it's trying to get rid of all the blood flow. As ovulation comes close to, the pulsatility goes up. So that's to aid the sperm to go in. So that's very common. And if you don't detect it, and I think it's a worry. I think you'll always detect some waves. The question here is there any role of sitting there for 2 minutes or 3 minutes and looking at wave patterns? And that's where science says probably we don't have the answer. Do you look at waves, Sachin?
Stop doing that.
Don't have time, Anil, to look at waves. Only when I'm on a holiday in Maldives, I look at the waves. I don't look at the waves on ultrasound scan. I've got another 15 patients waiting. I can see now Oscar laughing.
I think we keep debating all these issues about improving the thin endometrium. Again and again, we keep answering about sildenafils and so many adjustments to be done. But ultimately, the conclusion comes is just look at the endometrium. If you find it to be healthy and have good thickness, and you achieve that thickness in a certain amount of time, we just go ahead and transfer the embryos.
No, what is estradiol hemihydrate?
Anil, estradiol hemihydrate was available when, do you remember when Proganova had gone out of market for a little while? So it's just another form of estradiol, basically, and it does exactly the same.
Yeah, it's more soluble than the other estrogen, other than the Proganova, but I think it's a marketing gimmick. It's all the same. Yeah. You can use any one of them.
I agree. It's very much like that clomifene.
Yeah.
Doesn't make any difference.
Okay.
In fact, Indira, I do use a cusco speculum because I think it causes the least pressure. In fact, if you look at these studies which were done by Sims, they were done which clearly show increased pressure. And I don't use the Valsalem at all. I prefer, because if you see in the course that we did, Amit has shown a slide in that with every intervention, may it be the Valsalem, may it be the stylet, with every intervention, your pregnancy rates start going down. And he did that on in the course when he spoke about.
You might be able to show the slide, Anil, if you have got it on your.
Okay, while you talk, I'll have a look.
Yeah, I think with embryo transfer, as we discussed with Sachin, Anil, and me, showing various ways of doing transfers, the key bit is to keep it as atraumatic as you can. Do not use instruments to push-pull cervix, because that will generate your contractions and that will cause more problem. If you can use, and ideally you should use, a cuscos, Sims speculum, or holding it with a tenaculum or Valsalem is not a great idea. It's my absolutely last resort if everything else has failed. And as soon as you start to bring in those interventions, your chances of implantation reduce, bleeding increase, and also at times, because you're able to force the catheters through if it's not going, you will create false passages as well. So I would, it comes, if I've tried everything and I can't get it through, then I would rather refreeze the embryos, or if they're fresh embryos, freeze them rather than push them in, and then organize in a separate state a hysteroscopy or dilatation or whatever you want to do, and then do it. Because otherwise, it's a waste of embryo.
Okay, I'll just share the screen, Amit, from your talk.
Yeah.
So this was a study, I think we presented in a course that we do, and the analysis of 7,000 plus cases of embryo transfer. And when is difficulty encountered, inner sheath removed and resheathed, any resistance encountered, you use the outer sheath, use the Wallace malleable starlet, tenaculum, or hysterometer. So let's have a look at it. And what they looked at is when you did an easy embryo transfer and we did a difficult embryo transfer, difficulty reduced the chances of pregnancy. But this is something which is very good. If you had no additional maneuvers, then the pregnancy rate was close to 40%. As soon as you introduce every additional maneuver, your chance of pregnancy start going down. And the tenaculum tends to lower the chances the most, because I think it causes a huge amount of irritability. Yeah. I don't know about PRP. I don't use it. So at present, the evidence is very poor. Did I do it?
I mean, you're being very defensive. You're being very like a politician, saying, oh, I don't know whether I should. But the answer is no.
No,
you do know that PRP doesn't work based on the evidence that we have. Just because you haven't used it doesn't mean.
Even if I try to do it.
I don't know. No, you do know that it doesn't work.
I think it's.
You should become the new Prime Minister of England.
Yeah, it looks like it. He's my own MP.
You cannot do much worse than Boris Johnson.
So anything else?
What's the topic for next discussion next Sunday?
So we were talking about continuing finish of the endometrium with that compaction thing. I'll get as much evidence. I've got about 15, 16 slides. And if anything else you want to add on, Sachin, more than welcome.
Do you have any
topics? We can just dwell into all the publications on heparin. I'll just, because a lot of people are using heparin, I'll just go through the heparin part of it.
Sure.
Yeah.
No problem. Maybe, yeah. Heparin,
and Anil can try sildenafil.
No, I'm not going to read about sildenafil. I don't give it. It's too much.
Actually, try sildenafil.
Well, are you asking Anil to try it, or Anil to try it on a patient?
Yeah.
Okay. So bye bye. Take care. Take care. Jokes apart.
So I think what we'll do is Amit will present the compaction, and Sachin, if you look at heparin and aspirin, I think both together for IVF, and we'll present that.
Yeah, fine. Let's do that. Yeah.
Okay.
Okay. Excellent. See you, everyone.
Bye. Bye.
Bye. Bye.
Bye, Oscar. Gulam.
Bye. Bye.